Ryan Stanton here with ASEP Frontline, joined today once again with some so what. Well, so what today? Well, it's Howie Mell, that's so what. And we're actually going to be talking about the article that is making the rounds right now from the New England Journal of Medicine, Ketamine or Etomidate for tracheal intubation of critically ill adults from Casey et al. And this is a one that is, of course, because in emergency medicine we love ketamine. It is our baby. And then as well as Etomidate, which is the old fighter that's coming back to the ring once again. So when I saw this and I saw all the hullabaloo online, I thought, well, there's only one person I know that can, one, break this down quickly, and two, is a great interview about it, and three, so what? So what, Howie Mell? So what?
So what? So what? This paper is a nothing burger. I mean, the reality of it is this paper doesn't tell us anything. And what you have to start out with is the fact that it was set up and powered to a level that is ridiculous, right? So what they started off was they said, we want to detect an absolute mortality difference of greater than 5.2%. Now think about that. That's 1 in 20. Now, my problem with that is that we wouldn't need a paper to tell that. If there was a mortality difference at that rate, we would all already know it. It's a ridiculously huge mortality difference, right? I mean, think about this. Like, there are so many things that we do that the absolute mortality benefit is in the 1 to 2% range. I mean, it doesn't matter what you're looking at. This is not, they're looking for like a huge mortality difference in this paper, and that's not a thing. So what did they actually find? They did find a difference, and Etomidate was more harmful. They found a 1% higher mortality rate in the Etomidate group. As much as they don't like to talk about it, and as much as they like to say, well, we didn't really find it. No, you didn't find it because you set up your goal to be 5% so that you could ignore the 1%. I don't know. Matters to me, 1%. I mean, crap. We give lots of things at 1%. Now, if there was a lower mortality in the Etomidate group, I'd say we'd have something. But we haven't really eliminated the concerns that Etomidate increases mortality, right? We haven't proven that. They say they have, but they actually did find greater mortality. I mean, look at even in the raw numbers, right? They had 1,176 folks in the ketamine group and 1,189 in the Etomidate group. And what they found was that in the primary outcome, which was death from any cause by day 28, 28% of the ketamine, 28.1% of the ketamine group, and 29.1% of the Etomidate group died. And now the confidence interval does cross zero, so they didn't reach statistical significance with that. But again, remember why they didn't reach that, right? They didn't reach that because they weren't powered to reach that. And so that's problem one. Problem two with this paper is they set it up to fail. And what I mean by that is that if you look at the way that they administered the two agents, these were open. This was an open ended trial, right? People knew which drug they were giving. It was an open label trial. Now, the thing of an open label, the part of that makes this problematic is that they then talk about this secondary effect. And what they tested for the secondary effect was cardiovascular collapse during the interval between induction of anesthesia and 2 minutes after intubation. And what they found was that ketamine had a statistically significant difference in causing this secondary outcome, this cardiovascular collapse during the interval between inductive anesthesia and 2 minutes after intubation, right? That these people were crumping, that their blood pressure was tanking. Okay, except because it was open nature, it was open label, what you actually find out was that patients in the Etomidate group got prophylactic vasopressors at a much higher rate, 2% more likely, actually. And so that's a major confounding variable, because I will agree that this paper suggests that perhaps ketamine isn't as hemodynamically stable as we have previously thought, right? The old thing is, hey, if you've got somebody with a tenuous blood pressure, reach for the ketamine. It will help support the blood pressure. It's very hemodynamically flat. It's very hemodynamically stable. And maybe. But we all know that etomidate does cause hypotension. And so what you find is that this reduced hypotension in the etomidate group is probably because the treating team was ready for that, right? They were aggressive about prophylactic vasopressors when they induced. They were given push dose pressors, ready to roll. And so they prevented that hypotension. And the folks who were giving ketamine, much like most of us, work under this assumption that it's hemodynamically stable. So the problem is if you combined those folks that got prophylactic vasopressors at the time of induction with the vasopressor administration after induction, hey, guess what? It's probably not significant anymore. You probably haven't actually demonstrated what you think. And the other problem with this whole idea of this hemodynamic stability, hemodynamic instability, if you really found that ketamine caused 8% more hemodynamic instability of cardiovascular collapse, right? Oh my gosh, there's this huge likelihood of this cardiovascular collapse, then why isn't it causing death? Right? If ketamine is going to cause you to crump, okay, then why do you still die more often with etomidate? And the answer is, no, right? It's probably not as bad as we think it is. It just means that we do need to probably pay more attention to the idea that ketamine can cause some hypotension, and we need to be ready for that. And that's okay. I don't think that's a bad thing. I think that's probably one of the good things out of this paper. And it does raise the question, why are we dropping the BP, right? I mean, I think that I've always been taught it's going to increase it. I mean, haven't you been taught that? Or like it's the induction agent of choice if your pressures are soft?
Oh yeah. I mean, I get, it taught that that it's probably the better one for that situation. Of course, then it's but it's going to increase intracranial pressures, all that stuff, and all that bunk. But the challenge being that it makes sense that it's going to drop anytime you take away the stress of somebody trying to survive on their own by sedating, intubating, RSI. I mean, you're going to take away that stress response that has been keeping everything going to that point. I mean, so my expectation is no matter what I do, I'm likely going to see some drop in blood pressure.
Well, right, because we also have that fight or flight syndrome, right? And that's intrinsically tied to pain. I put you into a lot of pain. You've essentially given yourself an endogenous release of epinephrine, which is going to act as a pressor, right? And so remember that ketamine provides analgesia and sedation, but etomidate doesn't. It's just sedation. And so if you give etomidate and rock or etomidate and sucks, shiver, you haven't given any analgesia. But if you're giving ketamine and rock, you are giving analgesia. And so that idea that the sensation of pain can act as a pressor is probably some aspect of this, right? We're knocking out the fight or flight reflex entirely. We're stopping all of the pain with the ketamine, and that's all she wrote. And once you stop having that catecholamine surge with the ketamine, well, your pressure is going to tank. And so ketamine may be really acting to show you what's really going on, right? Like you get the person who's beaten or shot, and you're going to end up intubating them and sending them to the unit, right? You get the guy who's shot in the chest. What's the last thing that they remember going on? They remember whatever the heck happened that led them to getting shot. They're freaking the hell out, right? It's you can have a lot of amnesia after you get shot, right? You can have a lot of I don't know what the devil is going on, but one thing that we know you're not likely to have is amnesia for the events leading up to your injury. And so when you give this analgesia, when you stop all this pain, when you stop all this fight or flight reflex, I think what's happening is the ketamine is showing us how actually unstable the patient is. Now, the other problem with this whole thing is that there probably is some effect with ketamine as far as cardiac effects, right? We know that there may be some arrhythmia that can happen with ketamine, that there can be some cardiac irritability with ketamine, so that may play a role. There is certainly a longer duration with ketamine, right? And so maybe there's something there that's also causing good and bad insofar as with the Etomidate, you're going to be starting the propofol very early. You're going to be starting other adjuncts very early, and you may hold off with ketamine. I kind of like that longer duration of sedation. When I intubate, I don't know what you use. I always almost exclusively use a combination of fentanyl, ketamine, and rock. And if I've got a patient that is kind of intact with a normal blood pressure to start with, I'm going to use 3 micrograms per kilogram of fentanyl, 2 milligrams per kilogram of ketamine, and 1 milligram per kilogram of rock. And we'll get back to that in a second. And I find that it really gives me a nice 45-minute to an hour of sedation where I don't have to start anything else. And if I'm at a place where it's really effective, or if I'm in the field or I'm on a flight, it's great because I don't have to start milk of death, right? I don't have to hit them with the propofol. I can get everything I got to get done, and then I can send them upstairs and they can start that. So I like that longer duration of action. But again, I love the fact that we get analgesia from ketamine. I love the fact that, if you want to talk about delayed sequence intubation, you do get some protection of the airway reflexes with ketamine if you're not going to use a paralytic, although I don't know why you wouldn't. It's just hard to understand how they're going to defend this paper. I just don't get it.
Now, do you find that, or first and foremost, do you think that this paper, I think honestly, anytime you mention ketamine, you're going to get a huge response from emergency medicine and frontline emergency folks. Do you think that there's anything applicable from this study to the emergency medicine environment?
Yeah, I think because we use ketamine so much, and because there's always been this teaching that ketamine is very stable in terms of blood pressure, I think what this paper does teach us is that maybe that's not as true as we thought, right? And so I think what I would take from this paper, although I've really gotten in the habit of doing this, is to perhaps have a push dose pressor ready anytime I'm intubating. I think it also highlights the absolute need to resuscitate before you intubate as much as you can. I mean, obviously, there are some times that you can't. But I don't know that this changes my practice at all. I still don't see a time that I'm intubating with Etomidate unless I absolutely have to. I don't think, and this is really, I guess, where my biggest problem is that I don't think this says. I mean, this is almost like the Princess Bride, right? You keep saying that word, but I don't think it means what you think it means. Everyone online is talking about this as though this has proven that that Etomidate is wonderful, and it hasn't. Go to their primary endpoint. They trended towards greater mortality. They were underpowered for the 1% that they found, but they absolutely did not demonstrate that Etomidate was better than ketamine. And I don't think they proved that it was equal. I think, when you really look at this and when you look at all of the data that are out there, I don't think that you're going to find that Etomidate is that great. I think if we take all of the paper and all the experiences with ketamine, I think it's still the totality of the evidence. I have not done a meta-analysis. I've heard there is one hanging out there. I don't know if it's EM Crit, Palm Crit. It was somebody has done one, and it's kind of shown that ketamine is probably protective, right, for death. I don't think they've proven that Etomidate is worth using. I think the only thing that they've really shown us is that ketamine can cause some hypotension, and so I'll be a little less laissez-faire about that. Ketamine will hold my patients rock stable on their blood pressure, which is the classic teaching. Now, the other thing that this paper does not address at all is the fact that there is literature out there, especially in the pre-hospital world, that talks about the superiority of first pass success when you use fentanyl, ketamine, and rock for intubation. And that's a very common practice outside the United States. Like Europe uses fentanyl, ketamine, rock a lot. And so there was a pre-hospital paper that looked at first pass success, comparing comparably trained teams, one team using fentanyl, ketamine, rock, the other team using Etomidate and sucks, and they found that fentanyl, ketamine, rock absolutely led to much, much, much higher first pass success. Now, of course, that's not a double-blind randomized controlled trial, but then again, neither is this one. And that paper and the practices in Europe have led to some additional papers that have said, well, actually, you probably don't even need the fentanyl, right? There was actually a good paper, and I love the name of it. It was the FACT study, FAKT. It was fentanyl versus placebo with ketamine and rocuronium for patients undergoing rapid sequence intubation in the emergency department. And they actually looked in Australia at these folks who were going to be intubated with either fentanyl, ketamine, and rock, or placebo, ketamine, and rock. And they found that actually the fentanyl didn't really help, but it did cause lower blood pressures. And so, again, they were saying maybe we don't even need that fentanyl as a co-induction agent, right? Maybe we can just use the ketamine and rock. And I think we're starting to see a trend towards that. And it's interesting because I always like history, and I like to figure out how we got there. And the reason that we got to fentanyl in addition to ketamine and rock, do you know this one? Do you know why we do it?
No, I do not.
So when you have heard that old thing of ketamine is going to increase your intracranial pressure, right? That was teaching when we were in residency.
Oh yeah.
That was just ending. So the way that they did that, the way that they disproved that was Bolt studies in neuro ICUs. And they're good studies. They have the people who already had intracranial pressure monitors in place, and they gave them ketamine, and they determined whether or not their intracranial pressure went up. It didn't. But all of those patients were also being given fentanyl at the time. And so the purists said, well, we agree, it does not raise intracranial pressure, but you got to include fentanyl in the mix because that's how the study was done. All right, the study was done with them being down with fentanyl, and when we added the ketamine, so you're right, if you add fentanyl and ketamine, you don't raise the intracranial pressure. But you can't definitively say that ketamine doesn't because, the studies were all done with fentanyl. And that's how they started to use fentanyl as a co-induction agent. But there's now, getting to be a pretty good body of literature that suggests that maybe we don't need it. Maybe we don't need to be giving fentanyl, ketamine, and rock. We can just get away with ketamine and rock. There's also, always been this thought that there would still be some preservation of a gag reflex with ketamine and rock, and that the fentanyl would help to eliminate that. And I don't know. I think that the FACT trial and some other papers that have come out about, the fact that you don't need fentanyl with it kind of tells us that, maybe that's not as big of a deal as we once thought.
Yeah, I know for us that I've been a ketamine rock guy for quite a while now, and what's interesting, what got us there was kind of these off and on shortages that have taken place, and kind of figuring out what you like and the comfort with ketamine and with the rocks and Vex versus the traditional. I mean, when we both trained, we were probably in kind of the predominant Etomidate sucks kind of environment. And I mean, that's where you learn, but it's actually been as the evolution of practice. But we kind of talked about that a little bit because one of your episodes coming up for So What, it's going to be talking about some of the cervical spine literature that's out there. So much of what we practice, and I think speaking of your guest, Dr. Milne, he talked about how much of emergency medicine is actually based on high quality evidence, and I think that number is like 3%. But meaning that there's not doesn't mean what we do is wrong. It just means that there's not a preponderance of great evidence that much of what is done in medicine is based on just knowing physiology, knowing mechanism, and kind of translating that theoretically into a practice, and now trying to get some of this dogma out of emergency medicine when there isn't the evidence to support it, but now we're starting to get evidence that says it's not as important. I kind of think I found it interesting. While you were doing the discussion on this article, I was reading the conclusion again, and it does seem it jumps to conclusions that I don't think that the article itself actually supports. I think what it shows in this one is that sick people are sick, and that Etomidate and ketamine both work. They are both functional at being able to intubate patients.
I agree. I really don't see a time that I reach for Etomidate. I just don't. I mean, I get that this paper is claiming that the reason, or that the thought that it's going to cause corticosteroid suppression in the days following intubation may not be as prevalent as we thought. But to be honest with you, that was never the reason I didn't use Etomidate. I mean, okay, maybe, in second or third year when I would have one of my attendings really kind of pimp me out and say, oh, well, why would you choose ketamine over Etomidate, and try to make the point that this is what we know of Etomidate, and it causes this, and that's why you should use ketamine. Or that's why you should use, even a propofol induction as opposed to the Etomidate. But that was, and I get also that there were countries that pulled Etomidate, right? There were regulators that kind of said, oh, this is horrid, and there's this Etomidate-induced corticosteroid insufficiency that's gonna that's going to reach up and kill all your patients. So we should get rid of Etomidate, get rid of Etomidate, you know. And there were places that did. I don't think that is called for. I think the paper probably, while it doesn't disprove the possibility of death by Etomidate, because it was really underpowered to find what it did, those concerns were never the reason that I didn't use Etomidate. And so if you've disproven that aspect of it, right? If you've said, okay, well, as it turns out, there isn't this corticosteroid deficiency, so we can all use Etomidate again. You know, my answer was that was never why I didn't use Etomidate in the first place. So I really don't care that you proved that, and I don't know that you have. By the way, again, when you look at the paper and when you look at what it actually says in the data, it does not say that Etomidate is safer than ketamine. It says that Etomidate causes 1% more death than ketamine does. It just wasn't powered to reach significance. And again, it was an unblinded trial. So they were giving prophylactic pressors to patients that were getting Etomidate at a much higher rate than they were with ketamine. And then they're bemoaning the fact that ketamine seems to cause more hypotension. Well, duh. As it turns out, a patient without pressors, lower blood pressures than patients with pressors. I don't think that's any great shakes.
So let's jump into, so what? So is there anything in this paper that emergency physicians, critical care physicians, anybody out there, when they have their next intubation coming up, is there anything in the paper that you think should change our practice or our current approach to RSI or DSI?
The only thing I would say is for people that have it in their mind that ketamine can't cause hypotension or won't cause hypotension, I think they have effectively proven that it can, and in fact probably will in a lot of cases. So I think we should be more prepared for that than I think I've been, and I've seen a lot of my colleagues being. I think it also redemonstrates the point, always, resuscitate before you intubate. Whenever possible, you want to get these folks maximized. And, push dose pressors are your friend. You may need them, especially immediately after intubation with either agent.
All right. So, Howie, what are you working on? What can we hear in the near future on the so whats?
So in the near future and so whats, we do have a long discussion with Ken Milne. I think we're probably going to break that up into a two-parter on the history and the papers and the science behind C-collars, the fact that there really is none. I also have an interview with Eric Funk going over a couple of med-mal cases for you. And then we're going to just take a brief sojourn where I will do a wee little bit solo, just talking about some common scenarios that are faced in the community hospital and how I like to approach them with as best of an evidence base as I can. So we will look at a couple of those types of cases as well. I do have interviews coming up that I have to re-record, but looking at the response to the plane crash recently of the UPS jet and the absolutely massive EMS response that got brought about in that event, as well as an interview with with a expert in international and travel medicine, talking about some of the bugs that bugs cause. And so we'll be looking forward to those as well.
Well, we look forward to it, and kind of a breakdown of the Ken Milne discussion. As you mentioned, it's going to be perfect for the holidays when everybody's getting travel done, because of it being a very in-depth discussion and breaking it down. But as a primer, jumping into the Skeptic's Guide to Emergency Medicine, they break down the paper itself in his traditional format, of which he breaks it down. And they're going to take a much more deep dive on the so what side of it with Howie and with Ken. So a great discussion there, and look forward to that. How can folks reach out to you if they have any questions?
So as always, I can be reached at howie.mell@gmail.com. Yep, I'm old enough that I have my name with no numbers on Gmail.
I'm the same. Even though I had to put my middle initial, but the Ryan Stanton that has the Ryan Stanton, I think he's a grumpy elf because he does not like getting my emails. But as for me, to make it easier, you can contact me, rstanton@acep.org, rstanton@acep.org, and make sure that you're subscribed to the podcast, to the platform, to the network, so you can get the Frontline and So What feeds, as we will have more and more content coming out between the two of us. And until next time, I'm Dr. Ryan Stanton, and this has been some ASAP Frontline with a So What curveball.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Dinger. Quiet place, all
Yeah.
alone. Da, da, da.